I'm Bill Schwab, a family physician who practices at the Northeast Family Medical Center in Madison. I also serve as interim chair of the Department of Family Medicine and Community Health at the University of Wisconsin School of Medicine and Public Health. I'm proud of my profession, proud of my department, proud of my specialty of family medicine, proud of our medical school, and proud of my clinical organization, UW Health. It has become a cliche to say that our healthcare delivery system has been completely transformed over the past 2 months, but it is accurate, and it has been stunning in scope and speed as we have implemented this rapid transition to a completely different model of care that fits the needs of a society suddenly dealing with COVID-19. At the hospital level, frontline physicians, nurses, and other staff have not only faced the challenge of urgently learning all they can about an entirely new medical condition, but also how to provide care in new ways that are safe for patients, their families, our communities, and themselves as healthcare workers. No less significant is what we've done in primary care. The ongoing and acute medical needs of our citizens did not abate because of the presence of a pandemic. People with diabetes, hypertension, heart disease, and lung disease still need attention to their conditions. Prenatal care and well child care with immunizations are still essential for the health of mothers, babies, and children. Injuries and acute illnesses are still happening, and depression, anxiety, addictive disorders, and other behavioral health issues are not only still present, but increased. As COVID-19 first entered our midst, there was considerable uncertainty about safety issues for our patients and our staff, which led to canceling almost all office visits, as well as minimizing procedures and other hospital-level services. In our practices, we switched to alternately providing care through structured telephone visits, and in recent weeks, that has been supplemented by a marked increase in the use of video visits. These sudden changes have not been without cost. The irony in healthcare is that we have worked extremely hard to prepare and transform in ways that have actually had the secondary effect of dramatically reducing revenues and increasing expenses. And this has had major adverse impact on our workers and their families. But the costs have been high in other ways too. Delayed or deferred medical care may have long-term adverse effects, and the emotional stress for some has been exceedingly high. And all of the evidence is showing that there is unequal distribution of viral infection, of access to technology for alternate modes of care, and of economic impacts in communities of color and among people with disabilities in our state and nation, perpetuating and exacerbating already existing significant health inequities. But the greatest impact has been on people who have dealt with infection and on their families. I know this personally. On April 17th, my mother celebrated her 94th birthday. On April 18th, she was diagnosed with COVID-19. And on April 28th, she died at an assisted living facility in an adjacent state. A nurse here in Madison for nearly 30 years, her burial was attended by just 10 people who exercised the necessary precautions in this extraordinary time. Her family of 30 children, grandchildren, and great-grandchildren could not all be in attendance, nor could her large extended family and the many friends who had known her. Despite our depth of mourning, we all know this was the right thing to do at this time, yet it was still dispiriting. No one at her residence wanted to cause her to get sick. She was loved there. The facility followed all of the precautions that were understood at the time and provided attentive and tender care until her last breath. But we live in a microbially shared world in which your microbiology is my microbiology. And that was regrettably the case in the facility where my mother lived, as the microbiology of someone else who had been in contact with others became hers and ultimately led to her death. I can attest that COVID-19 is very real and that it can be devastating. More will be learned that will enable us to function better as a society as we make the transition we have currently embarked on from acute crisis status to chronic pandemic mode, but much will also remain unknown. In healthcare, we have learned enough about how to maintain safety for all to be able to resume offering services at our offices and hospitals in addition to the expansion of telemedicine. This requires knowledge, planning, and protective equipment. That same level of awareness will need to be scrupulous and universal across the breadth of our society if we are to maintain the necessary margin of safety. As I said at the beginning, I take great pride in what we in healthcare and at the University of Wisconsin School of Medicine and Public Health are doing. I can assure you that those of us in family medicine and other primary care specialties are committed to continuing to serve our patients with the highest level of care, regardless of the modality used to provide that care. And we will continue to partner with our colleagues in public health to promote the safety of the people of Wisconsin. It is said that statistics are human beings with the tears wiped off. I understand well the importance of statistics, and I have also experienced personally the tears that are embedded within them. My hope is that with the collective effort to maintain physical distancing and to follow other related recommendations, we can continue to have substantial viral control in our communities, and we can reduce hardship and deaths in our state. Thank you.